on Sub4 TV. I'm with Matt Hawkes, who's our physiotherapist at Sub4. If there's any speciality that you do, what would it be?
Well, I suppose naturally as a physio, with what we see caseload-wise, obviously you could say I'm a generalist really, because I do see anything from the feet to the hands to the head to the toes. You know, it's kind of all parts of your body, which is one of the things a lot of people sort of struggle with, because they come in and say, you know, oh, we've got this problem, can you help me with that? And 9 times out of 10, if it's in your body, you can usually help it. So fundamentally, I think, you know, that's one of the good things about physio, is that we're quite broad and generalist. But obviously, we do all have our special interests. So obviously, naturally, as you know, I suppose one of my special interests would be biomechanics, the lower limb. My background with regards to sport and things that I've done, and then naturally the people who come and see me in the past, because of that, have been like swimmers as well. So I suppose on that nature, I've got a special interest in swimming and swimming injuries, which then naturally leads you towards the shoulder. Now again, I wouldn't call myself a shoulder specialist, but I've personally also had injuries, as we all do, which included shoulder injuries as well, through swimming and weightlifting and various things. And yeah, so essentially I would say that I got like a bit of a natural affinity towards that with my expert knowledge, my experience, both personal and professional, and obviously who I know and who comes to see me. And obviously through you and working with you guys over the years, I've obviously seen plenty of the biomechanically related problems, and that means I have, compared to a lot of physios, a bit more of an eye towards that. So I mean, like just today, I had someone in who'd had a hip arthroplasty done, and effectively no one had seen NHS physios, all manner of people, private physios, and they had a rip-roaringly big difference in leg length, and in fact huge compensations to the way they were walking and functioning because of it. And effectively, you know, that was totally missed, and it was obvious to me, but that's because I've naturally been looking at them things and have got more of an affinity towards that, because I've seen what you've done.
And I think that's the thing, isn't it? It's like as a podiatrist, people tend to come to us with specific types of injuries, but as a physio, you've got to be able to know everything. So your kind of functional anatomy knowledge has to be vast, doesn't it? Really. Literally, like you say, from the tip of the toe to the top of the head.
It does really, and I suppose, I mean, I know some physios who would say that they, you know, if someone came with a hand problem, they'd be like, ooh, I'm not so sure, because truthfully, you don't see that many hands. But only the other week, and for several weeks, I've been treating a lady with a hand problem, and she's been improving loads, and she's even seen the NHS physios, and they have almost said, oh, no, we can't really help you with that and all that. So, again, even within physio, you're going to get some areas of physios who would be a bit like shying away from certain things. And I think even though physios are trained in biomechanics as an example, fundamentally some of them are still very skimming the surface of things. It's kind of like your GPs. You kind of know a little bit about a lot, but obviously you can always delve deeper. And I think one thing that I always try to do is to try to get as deep as I can with as many subject areas as possible, which is hard, and it means you're constantly always on the go looking at research, and obviously for me writing my blogs and stuff like that, but it's really, really good. You know, I get a lot out of it. Patients say they get a lot out of it as well, and it's just good all round really, because it keeps you current and keeps you in with as many things as possible. And that's the challenge really as a physio, because there is so much subject area. Like I say, apart from probably you now being different to the average podiatrist, it used to be very fixated on the feet, but obviously you can't do that, can you? Because everywhere interacts.
Changed massively.
Yeah, so you're much more looking at the pelvis and the effects of that. So you're almost like a hybrid almost. You're a hybrid kind of podiatrist stroke.
I think it's got worse.
Yeah, no, but it's good. It's the way we need to go.
And this is the thing as well. I think mine and your philosophy as well, isn't it? Is about the duration we spend with the clients. We like to get a little bit longer, but I try and make sure that my client doesn't stay on the couch for very long.
Yeah.
Because, and I think you're the same, we like to look at movement patterns, don't we? We like to see the client moving, do a bit of a gait analysis, whatever the injury. And I think you know, you run a little bit of a risk if you only have a client that comes in for your appointment and they only have a lying on the couch. So you diagnose on the couch, you do your treatments on the couch while they're lying down. Sometimes you can miss something important, can't you, in terms of the origin of the injury?
Yeah, well, exactly. I mean, the lady that I was on about earlier, she, in fact, surprised me because she looked so functionally poor with regards to how she was moving, And yet, actually, when I did have her on the bed, she was actually a lot stronger in areas that I just didn't think she was going to be strong in by far. So it didn't tally really, and in fact, that's what the evidence points towards as well. So it's like the glutes on the side, the glute medius muscles. You test them on a bed isometrically, and fundamentally, you've got to think, what's that really telling you? Because it's kind of like saying, if it was all about pure and utter strength of a muscle, you'd get Eddie Hall, a strong man. You're clearly stronger than a javelin thrower, and all the muscles the javelin thrower uses, yet won't throw a javelin as far as the javelin thrower, because it's not just about crude strength, it's about context, it's about what position you're in, it's about almost skill, acquisition and learning, so like say movement patterns and all the rest of it. So the bed obviously can tell you some things, but it can't tell you enough. You've got to see someone moving, and it's not just about walking, it's about bending and all manner of like occupational related and hobby related stuff.
Daily activities.
Yeah, definitely.
But again, you know, being biomechanically minded, you know, you're looking at somebody, say, with a lower limb injury, and often they have other injuries, maybe around the back, pelvis, and sometimes even right at the top of the head. So,
definitely.
you know, you can see these real kind of functional links where you have to be able to understand and address what's happening in one segment of the body can really be related to that other injury. Yeah,
it depends, because everyone compensates differently, don't they? So you've got some people who, you know, you're going to get on a leg length inequality, you're going to get compensations that are in the foot, and that might be enough for that person. But someone else might say, I have quite a rigid foot, and therefore they compensate in the knee. Someone else might have a rigid knee, like an arthritic knee, and maybe struggles to compensate there and compensates higher up. I mean, I've seen it in very rare cases, and it is rare, but the compensation, you can't see the correction for keeping their head level until you get to the neck. And you're thinking, I wonder why they've not corrected all the way up there and they're getting that problem higher up. And it is quite a leap of faith to make that call as to, is, say, a neck issue or a headache or something more higher up coming from something as low down as that. But truthfully, you know, I saw it firsthand once when you did come to a practice I was at in the past. And it was a bit of a fluke really, because the guy actually, he'd come in for something lower than him, and I think we tried a raise with him, and then I think he came back in, and he then said, you know what, I got headaches all the time, and guess what, they've stopped. And we were all like, can't believe it, because of course, if you look at the research on that, it obviously wouldn't support that, and that's because the research looks at vast numbers of people, and if there's only a small number of people who are going to get that good effect, then it rules it out. But that means that it would be effective for some people. So you've always got to entertain the fact that evidence can only take you so far. And obviously you've got to look at people individually, because they would have looked at just crudely leg length and then the correlation to, say, headache. Whereas we saw with like that guy, his correction didn't occur so much higher up, so that made sense with him. And therefore you think, well, let's see if it changes it, trial a raise, see if it improves it.
Well, you know, you have to try and be as evidence-based as you can. But as you and I both know, you know, for a technique that we might use, for it to be useful for someone on the other side of the world, you know, you have to have the research and you have to have the evidence before they can take it serious, because they can't necessarily come into your clinic and see you use it. Well, I think one of the problems with research is that everything that we do and every technique that is available hasn't thoroughly been researched yet. You know, and even though, you know, we have to kind of go where the evidence is and follow the research, because it means that we're safe to do that particular procedure with the patients. You know, you can't follow the research with everything, because often it's biased, often it's done on groups of students, often it's done in a way that isn't typical how you do something in a clinic. So it's important, but you do have to be a little bit wary.
You can't take it as being the be all and end all, and there are some people who are very fixated on it to the nth degree, but I think the problem is, like you say, the research that's done is in areas and fields which the money is there to be done. If you've got a niche area that perhaps is not in society as prevalent, one, you've got the issue of getting a sample size with your inclusion-exclusion criteria that would be relevant, and number two is who's going to fund it. Therefore, that piece of research never gets done. And actually may well be that the thing you're doing would be proven to be correct, but no one would undertake it because you just wouldn't be able to do it. It would get no backing, no funding, you couldn't get a sample size big enough to be taken seriously, and fundamentally you're kind of stuck, because then if you're the only one who chooses to do it, then you may find it by putting your money into it, but then obviously after that you're literally going to be stuck because they'll say, well, no one else has researched it, but no one else is going to.
Yeah.
So this is it. You've got to always take it with a pinch of salt, haven't you, really? But fundamentally, you've got to strike a balance, and where the research is, you go with it.
Yeah.
And when it's not there, you've got to go with what you feel and what you think based on experience and based on what you see clinically as well. So yeah, definitely.
So Matt, just to finish off there, and obviously you've been at Stockport as running your own company here in the Stockport Health Centre. We're very lucky to have you because we consider to be an eminent physio. But just to finish off, why would clients in this area come and see you as a physio in a sentence?
Okay.
Put me on the spot.
Yeah, I'll waffle a bit, so we'll struggle with this. But yeah, essentially, fundamentally, if you've got any problems, whatever you think it is, even if you're unsure, then the best thing is to come in, because most of the time, there's always something you can do. It can be something which is maybe not curable, but you can always help it. It could be something that could be fully curable, but you've also got to think about the prevention side as well. So the problem is sometimes you have a treatment with no real sort of backup to it. So it may well be that you've got back pain, you've been somewhere else, they gave you some massage, some mobilization, and that was kind of it. It solved the problem for a period of time, then it returned. Well, that's the issue really, is that you've got to back that up with something long term. So really, I always like to think the combination between manual therapy, hands-on treatments that give you pain relief and obviously help you in the here and now is obviously important, and that's what people obviously want. But you've also got to think, well, it's got to try and stay that way. So you've got to put things in place which can be related to biomechanics, obviously related to exercise, which could be strength or flexibility, related to movement and poor movement, so therefore advice, and trying to get to the root cause of the problem, and also trying to stay on top of that root cause, and therefore not only cure it now, but stop it from returning. So really it's thinking long term, and I think that's where my focus always is. I always try to be that short, let's get some effect now, but we've got to keep one eye on the long term solution really. So that wasn't one sentence, but there you go.
That was a long sentence. So there you go. If you've got any injuries and you're not quite sure whether you want to have physio or any other type of treatments, just come in and have a free chat. We're always available, and then you can decide.